Welcome back, everyone, and welcome to the afternoon programme of the 19th Latest in Advances in Psychiatry meeting. We've had a fantastic morning, and we're looking forward to having a fantastic afternoon. So just to say that you can always visit the booths for live chat with the medical teams. To guarantee an attendance certificate, you must put your email in the toolbar option available after the last break at 3:15. So we're going to kick off the first of two sessions before that tea and coffee break. The second session will be done by Professor David Knott, who will be talking about new mechanisms and innovative treatments in depression. This is a symposium organised and funded by Janssen and chaired by myself, and we look forward to that. But before that, we have Professor Hamish McAllister-Williams, my very good friend and colleague from Newcastle upon Tyne, who runs one of the leading mood disorders research groups and also one of the leading regional affective disorders centres for the treatment of severe mood disorders. And Hamish has really championed new ways of thinking about treating mood disorders. And he's going to be talking about that today. He's going to be talking about difficult to treat depression, combating therapeutic nihilism, and introducing the possibility of new treatment strategies. So it's with great pleasure that I ask you to watch Professor McAllister-Williams talk, and then there'll be plenty of time for questions afterwards, and we'll be able to probe the full depths of his knowledge with penetrating and insightful questions to which he will give expert and sophisticated answers. I look forward to that, but first, the lecture. Thank you very much.
Hello, my name is Hamish McAllister-Williams from Newcastle University, and I'm going to be talking about difficult to treat depression. It can be difficult at times not to become rather nihilistic regarding treatment of difficult to treat depression. And we also can face challenges as to knowing when it might be sensible to try new treatment options. And that's what I'm going to be focusing on during this presentation. These are my disclosures of interest. I've worked with a number of different companies. I'm not going to be speaking about lots of different specific treatments. I am going to mention two, one from LivaNova and another one from Janssen, but I'm going to be using them as exemplars predominantly. So this is a study from the United States, very famous study, the STAR-D study, and it's looking at the response to first, second, third and fourth line treatments of patients with depression. The conventional definition of treatment-resistant depression, or TRD, is failure to respond to two different treatments. So all of those individuals who failed step 2 in STAR-D would be given a description of suffering from TRD. That is a pretty well accepted definition, and there is good general consensus that TRD is defined as failure to respond to two adequate courses of antidepressants. However, actually, there is a total lack of consensus regarding many elements of the definition of TRD. For example, how long does the course of treatment need to be for? 4 to 6 weeks? 8 weeks? Longer? What constitutes an adequate dose in a treatment trial? 20 milligrams of citalopram, is that enough? Does it need to be 40 milligrams? What about 75 milligrams of venlafaxine? 150, would that be enough? Does it need to be 225 of venlafaxine? Do we need to use drugs from different classes before we can say somebody's got TRD? Is a trial of 20 milligrams of fluoxetine followed by 20 milligrams of citalopram adequate? And what constitutes a different class? Remember that in terms of conventional descriptions of classes of antidepressants, we've got some terms which reflect the structure, the chemical structure of the drugs, like tricyclic antidepressants, and we've got other classes named after their pharmacological actions, such as serotonin and noradrenaline reuptake inhibitors, SNRIs. both of these drugs, TCA or groups of drugs, TCAs and SNRIs, are pharmacologically actually doing something rather similar, blocking the uptake of 5-HT and or noradrenaline. So if we use a TCA, does that make it sort of fair to say we've now used a different class of a drug if a previous one was with an SNRI? There is no consensus over this. Then there is the issue about what is it we're actually looking for. When we say there's been a failure of a course of treatment, what constitutes failure? Is it a lack of remission, full resolution of symptoms, or is it just lack of response, which would be, say, a 50% improvement of symptoms? And how do we assess that? Do we just say to the patient, have you got any improvement or not, and make some very subjective judgment? Do we use a rating scale? And if we use a rating scale, is a self-rated rating scale okay? Or do we need to use an observer rating scale? There's no consensus. And then I think very importantly, pretty much all of the definitions of TRD that are out there in the literature only focus on pharmacotherapy, and they don't consider psychotherapy or neurostimulation. If somebody has had a good going course of CBT and then failed a good trial of an antidepressant, do they have TRD, or do they have to have 2 antidepressant failures as well as a failure of CBT? And then what about neurostimulation? We're getting an increasing range of neurostimulatory techniques, transcranial direct current stimulation, repetitive transcranial magnetic stimulation, ECT, and others. I'm going to come on to mention VNS in a little bit. If somebody's had a course of ECT and failed a trial of a drug, technically they wouldn't be defined as having TRD. Is that right, or is that wrong? So lots and lots of problems with regard to the issue of TRD. Let me come back to one element of that, and that is to do with what constitutes an adequate response and what our goal and target is when we're treating an episode of depression. So here we have a schematic that most of you will have seen before. This is looking at depressive symptoms in that yellow line, an individual going into an episode of depression and then the symptoms improving and reaching remission. Remission is our null target. That tends to be what we would be arguing, we would be aiming for when we're treating somebody with depression. We want them to be symptom-free. But unfortunately, not all patients do, and there are a variety of different outcomes that can occur. So we can have, for example, individuals with complete non-response. They get into an episode of depression and they remain profoundly depressed over a prolonged period of time. They may show some improvement, which might be related to treatment, it might not be, but then they get stuck. They have a partial response, and technically a partial response, that line could have been drawn anywhere between the lowest point in that curve and pretty much the highest. So it could be a partial response that was more or less than a 50% improvement in symptoms, but it's still only a partial response because the person hasn't got full remission. Remember that a response is just a 50% improvement in symptoms. So if somebody improves by 50%, technically they've had a response, but if they get no further improvement, they're stuck at that point and they won't reach recovery because they've never got to remission in the first place. After somebody's gone into remission, if they've stayed in remission for a substantial period of time, 6 to 9 months or more, then we would say they've recovered from this episode. And recurrences can occur. And relapses would be the definition or the description of a recurrence of symptoms, or sorry, a return of symptoms before recovery has been achieved. Now, whether it's a relapse or recurrence, at the end of the day, if that is occurring, individuals are starting to have multiple episodes. So you can have individuals who might go into full remission, but then just keep having multiple episodes of depression. That also is not, obviously, a good outcome. We also have patients that never get to remission, but whose severity of symptoms also waxes and wanes. And I think we see that an awful lot in secondary care and in primary care with patients whose depression is proving somewhat difficult to treat. So lots and lots of different outcomes for our patients with depression. So let me just go back to the STAR-D results. I've shown you earlier on. This is looking at the rates of remission with first-line treatment. It happened to be with citalopram. And then second, third, and fourth-line treatment. There were a variety of different treatment options that were allowed at steps 2, 3, and 4. But what you can see is that there is overall a reduction in the remission rate with increasing treatment step. This is where we can start becoming rather nihilistic with regard to treatment, because actually the reality is the probability that a person will remit to the next treatment we give them after they fail to respond to 2 treatments is not very big at all. It's only 10 to 15% if we follow the study data. What happens if somebody's failed to respond to 4 or 5 different treatments? We don't really know, because we don't have good data beyond step 4. It could be that the remission rates sort of get a bit stuck around 10, 15%, and that would probably be my guess, but it might still be edging down a little bit further than that. Now, that's one side of where we have a problem with regard to managing depression. But if we look at the study data, there are some other rather not such good observations that we can make. The first is that if we look at relapse rates, the rate of relapse goes up with treatment step. In other words, the harder it's been to get somebody well, the more likely it is that they will actually relapse. And then there's a third element here as well. We can look at the tolerability or intolerance to treatment, and we actually see intolerance going up with each individual treatment step. That's not a great surprise, because we use a really well-tolerated treatment first line, and we reserve less well-tolerated treatments for steps 2, 3, and 4. But what we've essentially therefore got is a triple whammy of problems, that if we don't get patients well with our first treatment trial, we are starting to go down a slippery slope of increasing difficulty in treating our patients. And what this also illustrates is that the notion of thinking about poor outcomes in depression being defined by treatment-resistant depression isn't necessarily helpful, because the definition of TRD is simply on the basis of a lack of response or remission to acute treatment trials, when in fact we've got 3 different ways that patients can end up in a situation of having poor outcomes. It could be that failure to respond. It could be failure to retain or sustain a response, or it could be failure to tolerate treatment. If we put all of that together, it's no great surprise why we actually see that the long-term outcomes of many patients with depression are not good. So if you look at the top Venn diagram here, this is looking at the outcomes of patients presenting with the first episode of depression followed up for over 12 years. And what we see is that slightly less than half the time they have no symptoms, which means that slightly more than half the time, i.e. slightly more than 6 years of the 12 years of follow-up, patients had symptoms. They may just be subsyndromal, but we know that even subsyndromal symptoms are associated with impairment in psychosocial function and quality of life. But there's also a significant proportion of the time that they have mild depression or full-blown major depressive episodes. So the TRD model of looking or defining poor outcomes as being non-response or non-remission to 2 different treatments implies that if somebody's has got treatment-resistant depression, that the thing to do is try again and try and get the person into remission. That's a worthy aim. That is definitely a worthy aim. And if that fails, what do? Try again. Oh, okay. And it encourages you just keep trying and trying and trying again. But the problem is we've got very little evidence, good evidence, to support treatments beyond step 2. We've got really no evidence around multi-step treatment plans or algorithms as to how we would go about this once people have failed 2 or 3 steps. We're not really thinking about what the patients might see as being important with regard to their outcome. And we may be giving patients increasingly burdensome treatments that have got a greater side effect burden. And also it's pretty demoralizing, both for the patient and for the clinician, just to keep trying treatments endlessly and these treatments not working. And that's where the nihilism can come from. And we might be missing opportunities, actually, with this particular approach. And I'll explain what I mean or why I think that's the case in a little bit. But let me just sort of emphasize this issue and problem that we can have with the try and try again approach. How long should you keep pursuing sequential acute treatment options? Well, the British National Formula includes over 30 antidepressants, and the British Association for Psychopharmacology guidelines includes 7 first and second line augmentation strategies. So if we try just half the antidepressants and just 4 of the augmentation agents, and the trials last just 3 months, it's going to take a little bit of time to switch from one to another and to increase doses, etc. So not unreasonable to say that a trial might last 3 months or so. In practice, actually, people are on trials for much, much longer than that. But if they are just for 3 months, it would take 15 years to try all the available combinations. And that just does not seem sensible. Going on for 15 years trying treatment after treatment after treatment in a try and try again approach. And it was concerns like these, this problem with the try and try again approach, and also the fact that it isn't just non-response that leads to problems with outcomes, that led to a group of 3 psychiatrists, John Rush, who was the lead investigator for the STAR-D study, Scott Aronson from Baltimore, and Koen de Meetenaar from Leuven in Belgium, to come up with a proposal that rather than thinking about treatment-resistant depression, we should reframe poor outcomes, at least clinically, as difficult to treat depression. So DTD rather than TRD. So let me just explain a little bit more about what the difference is between these 2 concepts. There are clear semantic advantages, I believe, in referring to individuals having difficult to treat depression rather than treatment-resistant depression. I think DTD implies a more collaborative concept. It's proving difficult to treat for everybody, the patient and the physician. Treatment-resistant depression, well, who's being resistant here? The depression, the patient, and TRD can lead to that sense of hopelessness. You've got treatment-resistant depression. So that could just imply it's never going to get better. Now, difficult to treat depression, okay, the word difficult might be seen as being difficult as well, but difficult doesn't equal impossible, and that's important to emphasize. In terms of definitions, I've already sort of emphasized this. TRD is defined on the basis of failure to respond to acute treatment trials, whereas DTD is really defined upon lack of response or remission, or not being able to sustain this, and that would also include as a result of lack of tolerability. Critically, the DTD model is much more based around a chronic illness model rather than an acute illness model, thinking depression is simply acute episodes. The chronic illness model of DTD draws heavily upon the models used for in other areas of medicine, such as dealing with rheumatoid arthritis or hypertension. It also emphasizes a holistic approach, a biopsychosocial approach. And in terms of management, the emphasis is on searching for tractable, treatable biomedical and psychosocial causes of the poor outcome. And also there is subtly, or can be subtly, a shift in treatment goal away from remission, which is very laudable, but maybe towards optimal management in situations where we are really struggling to get full remission over substantial periods of time. The end point, instead of it being simply remission or not, it's actually thinking about symptoms, functioning, and importantly, quality of life, accepting that symptoms may well be waxing and waning. So I was very privileged to be one of a number of experts in mood disorders from around the world that got together in 2019 to come up with a consensus around how we might manage difficult to treat depression based upon that model that I've just described. And the paper was published in 2020. Now, in that paper, we emphasize that the starting point of managing DTD is an assessment. And I've put there a table listing all of the blood tests, vital signs, rating scales, etc., that might be considered both in primary care and in specialist care. I'm not going to go through those. You can see those by going to the paper, and I believe the slides will be made available for you as well. I don't think there's anything particularly surprising in those, but I do think it is trying to emphasise the importance of being thorough with regard to your assessment of patients. And then we talk about three particular steps. Firstly, reconsidering the differential diagnosis. There are going to be a number of diagnoses that you want to consider, but I guess one of the big ones is bipolar disorder. We know that there is a high rate of undiagnosed bipolar disorder in patients that have been described as suffering from TRD. So check, could this patient actually be suffering from bipolar disorder? And that's why they're not responding to antidepressants particularly well. Any patients with mental health problems, any patients with mood disorders, any patient particularly with difficult to treat depression is likely to have high rates of comorbidities of all types: psychiatric, physical, substance misuse, and iatrogenic from medication. These comorbidities need to be identified and treated, because if you don't address the comorbidities, you'll have continuing problems with poor outcomes. Any comorbidity of any type is associated with poor outcomes. And then thirdly, the critical thing is identifying predisposing and precipitating and perpetuating etiological factors that might account for not only this person getting depression in the first place, but also why this depression is proving difficult to treat. And the idea here is going back to one of those major elements of the concept of difficult to treat depression. It's trying to identify things that may be tractable that are perpetuating this depression. What is it that we might be able to target to try and turn this difficult to treat depression into slightly easier to treat depression? An example might be identifying that the patient has actually got hypothyroidism, or it might be identifying that there is unresolved trauma that's ongoing, and therefore a course of EMDR might be in order to actually try and help get to a point where the depression becomes easier to treat. Now, in the paper, the consensus paper on DTD that we published, we then go on to think about the principles and practice of managing DTD, and we came up with 6 principles and 8 points in the practice of managing DTD. And what I'm going to do is I'm going to run through each of these in turn. So let's just start with the first 2 principles, enhancing engagement and retention in services, because these patients will often feel very worthless. They're just wasting the clinician's time. And also the importance of shared decision making. That's going to be important because there are so many options for managing depression. That's a good thing. But it means that we need to be able to engage with patients to think through what the options are and keep the patient on board to enhance their engagement. And these are ways of helping challenge that nihilism that I mentioned right at the very start. We emphasize the importance of measurement-based care in the paper because of the strong evidence, such as the study shown on the slide here, that if we simply measure the severity of depression, we get significantly improved outcomes. This was a simple study comparing patients who had standard treatment, which was using either mirtazapine or paroxetine, and patients who had exactly the same treatment options, but whose clinician was provided with rating scale scores of the patient's depression on a repeated basis through the course of the study, which lasted 6 months. If you look at the standard-based care, what you see is about 30% of patients achieved remission over the 6 months. But in the measurement-based care group, it was nearly 80% of patients who got into remission. And they got into remission much faster. So how was it that simply measuring the severity of somebody's depression leads to such better outcomes? Well, in the measurement-based care group, what was seen was that patients were much more likely to have their dose of antidepressant increased and the antidepressant switched to an alternative sooner than in the standard treatment group. And what we know is that the sooner you can get a depression under control, the better the outcomes. So really it is critically important to employ measurement-based care. This is recommended by NICE, and you would never think of treating hypertension and not measure blood pressure. Why do we treat depression and not measure the severity of depression? How do you measure the severity? Could be PHQ-9, it could be the QIDS-SR, which is one that we favour in our clinic. Self-rated scales, I think, are very helpful. They save us time, and actually they're just as good, if not better, than clinician-rated ones. Now, the next three principles, self-management strategies, service pathways, and reassessment, are also featured over in the practice items. So I'm going to ignore them just now because I'll come back to them, and I'm going to just focus now on the 8 steps regarding the practice of managing DTD. And in the paper we came up with this figure here, a bit difficult to read, well, pretty much impossible to read on the slide just now. We've got 8 steps there, that's the 8 green boxes, and what I'm going to do is I'm going to run through them in turn. So let's start with 1, 2 and 3, and I'm going to blow up the figure from the paper and focus on number 2 and 3. We argue in the paper that it is really important to target some symptoms at times with patients with difficult to treat depression. It can be important to target symptoms that might in of themselves be associated with a poor outcome. We know, for example, that patients who have high levels of baseline anxiety or pain have worse outcomes when we treat them with antidepressants. So we need to assess for these symptoms and we need to target them. That might be using an antidepressant that will kill 2 birds with 1 stone. So an antidepressant that treats anxiety, an SSRI for example, or an antidepressant that also treats pain, an SNRI, venlafaxine, duloxetine, or amitriptyline, for example. Or it might be using additional treatment to target the anxiety, it might be augmentation with quetiapine, or it might be sending a patient to a pain clinic for further assessment and management. We also think that it is important to think about targeting symptoms that we know are associated with poor quality of life and impaired function. That is because the DTD model is emphasizing the importance of trying to enhance function and quality of life. So we know, for example, sleep problems can be very problematic to people and impair their quality of life. So it might be thinking about, do we need to use a more sedative antidepressant, or do we need to be considering something like CBT for insomnia? Fatigue is a really big issue in terms of quality of life, and it can be a real problem managing it. One augmentation strategy that can be used, included in the BAP guidelines, is modafinil. But I think short of going for modafinil, I think it's important checking the patient's medication. Are we over-sedating them? And also looking about whether we've actually optimized management of their sleep and that we're not dealing with a sleep problem, which is then leading to daytime fatigue. Cognitive problems in many ways are even more problematic. There is some evidence for vortioxetine, treating cognitive problems associated with depression, a little bit for duloxetine in the elderly, and there is also, again, some data for modafinil augmentation. But it is a challenge, and there are psychosocial interventions like cognitive remediation. Let's now go back up to number 1, optimizing symptom control. And that is all about using our conventional treatments in a sensible, structured way, so that if a patient doesn't respond to first-line antidepressants, we think about increasing the dose, we think about switching drug, or we might be thinking about augmentation, perhaps after they failed 2 courses of monotherapy. It's thinking about psychotherapies that might be used, high-intensity psychotherapies, maybe going beyond IAPT, which might be used first line. So if somebody's had IAPT and not responded, Might they need a more a higher intensity psychotherapy like CBT, potentially with medication, because there is evidence that CBT plus medication is better than either alone? And do we need to be thinking about neurostimulation, for example, ECT? There might be an increasing number of first-line neurostimulatory techniques like TDCS or TMS, and if those have been tried, maybe you want to move on to an alternative such as ECT. But I guess in secondary care, in many ways, what we need to also think about is going on to less conventional treatments. And by that, I'm really meaning treatments that are not included in current guidelines as routine first, second, or third line treatments. So let me give you two examples. The first one is S-ketamine, and we have evidence that S-ketamine in combination with a new antidepressant being better than a new antidepressant alone, as shown here. The interesting thing about S-ketamine is that it has a very rapid onset of action. You see an effect by day 2 after intranasal administration. And if you keep repeating administration of the S-ketamine, that beneficial effect can persist. So a treatment that works very rapidly. I think it's unlikely you're going to be using S-ketamine third line. It's going to be fourth line or maybe beyond. And I'm recording this lecture at a time while we're awaiting NICE to make a decision as to whether they're going to recommend it for use in routine care or not. By the time you see this video, that decision may be out in the public domain. An alternative treatment with a very different temporal profile is vagus nerve stimulation. It requires a surgical implantation of a pacemaker-like device, such as this one, into the chest wall with a wire underneath the skin up to the left vagus nerve. And we have evidence from non-randomized collection of data in a registry over 5 years that patients with vagus nerve stimulation plus treatment as usual do significantly better than patients with treatment as usual, but not the vagus nerve stimulation. And this is a non-randomized study, but patients were similar at baseline. Very, very different time course. We don't expect to see benefit of VNS for 6 to 12 months after implantation. So totally different to S-ketamine, which might work in days. VNS, something that might work over a long period of time. S-ketamine, intranasal administration requires to be done in hospital. A course of S-ketamine does have a significant financial cost. It may be cost effective, that's a value judgment, but it's still a significant cost. Vagus nerve stimulation, also significant cost and requires a surgical operation. So when are you going to consider using these compared to a trial of citalopram or a trial of venlafaxine? Well, a couple of years ago, myself and some colleagues from other tertiary level mood disorder services, some secondary care clinicians and some primary care clinicians got together to try and grapple with this question, to try and identify as early as possible the point when non-standard or non-conventional treatments might be considered. And the fact of the matter is that point will differ between different treatments. It might be different for S-ketamine compared to vagus nerve stimulation, or modafinil for augmentation, for that matter. And we came up with these recommendations. Now, again, I don't want to go into these in too much detail because the actual threshold will, as I say, vary a lot from one treatment to another. But just as a broad brush sort of illustration, the idea is that you'd be looking for failure of a couple of trials of psychotherapy, 4 different antidepressants, and we say something about what those antidepressants should be, a couple of trials of augmentation, and trial of ECT. But note in bold, in red, that it's a failure to respond or achieve remission, or maintain this, or tolerate it, i.e. consistent with the DTD model, or the patients refuse treatment, or the treatment's contraindicated. So if the ECT is contraindicated, we're not saying, well, sorry, that means you can never meet this threshold and therefore never be considered for non-conventional treatments. Okay, so that's something about treatment of symptoms, symptoms that we should be targeting, and choice of treatment and when we might choose different treatments. What else have we got in terms of the practice of managing DTD? Well, I've already mentioned comorbidity, but it requires to be mentioned again because it's so damned important. We need to screen and treat for any comorbidity, physical, substance, psychiatric, iatrogenic. And because it can be so difficult getting patients with difficult to treat depression, well, we've got to try and do whatever we can to keep them well once we've got them better. And the rule of thumb is that what gets you well is what keeps you well. So we need to make sure we are optimizing long-term outcomes by ensuring adequate prophylaxis. We need to encourage self-management. I think this is vitally important because it empowers patients and also emphasizes the importance of it not being a passive situation for them, that it is all about the healthcare staff around them finding the answer and giving them the magic answer that's going to sort out their depression. If you take the middle line of this box of 9 things to do, good sleep habits, exercise, good diet, all critically important. Bottom line, help people to think about how to cope with any residual symptoms they have. Think about whether there need to be any occupational changes to be able to help them adapt to maybe some issues of ongoing residual symptoms. We want to get rid of those residual symptoms if we can, but if we can't, we still want them to be able to engage in occupation if they can. There are lots of online tools now for managing depression and anxiety and sleep, and we would encourage the use of those. Top line, middle, behavioural activation, one of the most important things. If people aren't being active, how will they know whether their depression has improved at all with the treatments we're giving them? And that may also include active community reconnection to try and challenge isolation, something that has been so difficult during the COVID pandemic. But the top left box is one of the most important of all. We need to encourage skepticism of that pervasive view that things are never ever going to get better. We need to encourage that view in our patients, but also in other healthcare staff and ourselves. And the DTD model, emphasizing that the treatment is difficult but not impossible, and giving you various different strategies to try, is one of the ways of actually doing that. We need integrated care pathways, patient centre, access to primary and secondary care as appropriate, and highly specialised services for some of those non-conventional treatments. This is a counsel of perfection and can be a bit of a challenge in the UK at the present time. But very critically of all to the management of DTD are regular reviews. When we go and reassess the severity of symptoms, the impact on functioning, reconsider the diagnosis again, screen for comorbidities again, review the 3 Ps, predisposing, precipitating, and perpetuating etiological factors, and then thinking, what medication could be withdrawn? Because these patients attract medication like magnets. What medication could be further optimized? Are there any new medications that could be considered, either as a switch or as augmentation? Are we thinking about all management options? Medication, psychotherapies, neurostimulation, and there's an increasing number of them, psychosocial, social prescribing. Are all of these things being considered? And should we be considering referral to a highly specialised service, such as the one that we have in Newcastle, the Regional Affective Disorders Service, where we might be able to consider other non-conventional treatments, for example, vagus nerve stimulation. So there you have it. 6 principles and 8 steps in the management of DTD. And what I would argue is the DTD model offers hope by emphasising that difficult doesn't equal impossible. It offers a clear strategy as to how we go about approaching the management of difficult to treat depression, or any depression for that matter. And there is an emphasis on the importance of considering non-standard strategies in a timely manner. So thank you very much for your attention, and I hope that this presentation has been useful for your day-to-day clinical practice.
So thank you very much, Hamish. Great lecture, and we've got a lot of questions, and we've only got 6 minutes or so. So question number one, should we be requesting a vitamin D level as part of our routine blood work following admission to a psychiatric ward? And should we think about vitamin D therapy for depression?
Well, I think that in terms of the generality of the question, we should definitely be thinking about what investigations may be appropriate to consider what underlying causes of difficult to treat depression there might be, or underlying perpetuating factors for the difficult to treat depression. And that could well be low levels of vitamin D, and therefore vitamin D replacement might turn a difficult to treat depression into an easier to treat depression. My experience has been that if you give vitamin D to people, that doesn't suddenly stop them being depressed, even when they were vitamin D deficient. But correcting that may be facilitatory with regard to antidepressant treatment.
Thanks. Does the DTD model account for anatomical brain differences, anatomical brain abnormalities?
Well, yeah, I mean, the DTD model, it's more about how we think about managing patients presenting with depression. I think that's the important point. So I'm not sure that I totally get the question. If somebody has got depression because of a brain neurodevelopmental problem or a brain abnormality, then that is one of the etiological factors. So what the DTD model is saying is we need to think carefully about the etiological factors and identify any that are tractable, and then address those to try and make a difficult to treat depression somewhat easier. Now, the particular ones that are being referred to there might not necessarily be so easily tractable, although there might still be things that are possible to be able to be done if we can identify those etiological factors.
Great. So 2 questions in one. What was the measurement scale that you mentioned using, and do you feedback scale scores to the patients?
Yeah, okay. So in the study that I presented from 2015, the rating scale that was used there is the one that we actually use in our clinic, which is the Quick Inventory of Depressive Symptoms self-rated version, the QIDS SR. And in that study, patients completed the QIDS each time they were seen by the psychiatrist who was looking after their depression and prescribing the medication. So the patients were aware of what they were putting on to the actual quiz. What I don't know for absolute 100% certainty is whether the total score was reflected to the patient in that particular study. But it's a self-rated score, a scale, so they would be pretty clear what sort of things they were putting down on it. Do we reflect scores? Yeah, most definitely we do. We certainly reflect QIDS scores to people and use those as a way of monitoring changes in their depression following treatment.
So thanks very much. We favour the QIDS self-rated, but we've also developed the Maudsley visual analogues, which are 10 centimetre lines for depressed mood, suicide and anhedonia. Just published a paper showing that this very, very simple way of rating this is actually very comparable to the QIDS. That's in a one-off snapshot way, but we've also got probably about 150 people where we've measured change. Mm-hmm. We'll be publishing that at some point. The idea is to get very tractable. Well, I suppose I'll just follow up your comment by saying the actual scale that's used is probably much less important than actually using something to measure. Yeah, that's why something as simple as possible is a good thing. What about TMS in DTD? Yep. I think that the principle of DTD is thinking as absolutely as widely as we possibly can about all therapeutic modalities, medication, neurostimulation, and there are now an increasing number of those, psychotherapy, psychosocial intervention, self-help that I mentioned in the presentation. So yes, we definitely should think about TMS. I think TMS, the place where it might fit is particularly between for people who've maybe failed a couple of antidepressants, but maybe less than 5 or 6. I don't think it's as effective as ECT. I would use it earlier in the treatment algorithm than failure of 2 antidepressants for somebody, say, who is struggling to tolerate medication, not wanting to take medication.
And then there's a potential niche, which I think needs to still be explored a bit further, which is depression in pregnancy, where TMS is a potential alternative to actually taking medication.
Yeah, we keep writing a grant for that keeps getting rejected for TMS in pregnancy. What about irreversible MAOIs? Is Newcastle cocktail still available to be used?
Yeah.
Is that it? Just yes. I mean, lots
yes,
of people
it is.
talk about not being able to get phenelzine from their pharmacy and so on.
Well, there's definitely been supply problems with phenelzine. At this moment in time, it is possible to source it. We also do use oral selegiline, and we do use some transdermal selegiline. The transdermal is blimmin' expensive. Has to be imported, so it has to be prescribed via a hospital pharmacy, but is very well tolerated and is a very easy MAOI to use. But the downsides mean that we really don't use it very much at all. But I think the irreversible MAOIs, phenelzine, oral selegiline, are definitely options, and we use them not infrequently in our clinic.
Yeah, absolutely. In the Maudsley Clinic, we use them as well. I think there's real problems with supply, but we've just got David Taylor to import a block bulk. So we'll be advertising that we've got it is available, and they may want, I've asked David to get in touch with you, Hamish, because you may want some of this supply as well. Because to make it economical, it's got to be a bulk order, if you see what I mean. We're out of time. Fascinating lecture, informative, educative, and clear as ever. Thank you so much, Hamish. I look forward to hearing more from you in future, but we'll have to go on to our next talk now. So thank you very much.